Hypernatraemia is one of the most common electrolyte disturbances seen in the ICU. Hypernatraemia has been independently linked to increasing mortality in ICU patients, so it is important to recognise and manage this promptly. Sodium is the most common extracellular cation. Its concentration in the extracellular fluid is tightly controlled to values between 135 and 145 milliequivalents per litre. It is regulated not by controlling the absolute quantity of body sodium, but by regulating the volume of water it is dissolved in. Water balance is largely achieved by the release of antidiuretic hormone, otherwise known as arginine vasopressin. Osmoreceptors in the brain respond to the high plasma osmolality by releasing ADH, which regulates water balance by stimulating production of aquaporin. This in turn allows water to be reabsorbed from the distal convoluted tubules and collecting ducts of the kidney. When the production of ADH is maximally stimulated, the urine can be concentrated to nearly 1200 milliosmoles per kilo of water, greatly in excess of the normal plasma osmolality. Water balance is also maintained by stimulation of the thirst mechanism and other behavioural adaptive responses. Because thirst is such a powerful instinctive response, hypernatremia rarely occurs unless the thirst mechanism is disrupted in some way. Because of these mechanisms, hypernatremia usually reflects an issue with total body water regulation rather than the total body sodium levels. As total body sodium levels increase, water is retained to maintain concentrations in the normal range. This leads to an expansion of the extracellular fluid space. This causes tissue oedema and increasing intravascular volume. These both lead to regulatory mechanisms such as the release of natriuretic peptides from the atria and ventricles that can cause increased sodium loss. Hypernatremia is defined as a serum concentration of sodium in excess of 145 milliequivalents per litre. As mentioned previously, the thirst mechanism is extremely powerful. As such, hypernatremia will rarely occur unless there has been some disruption of this response. Water loss is common in ICU patients. Osmotic diuresis can occur for many reasons. Hyperglycemia is the most common cause. High urinary urea clearance occurs in a patient who is in a hypercatabolic state or when administered high protein feeds. The high urea causes an osmotic loss of water. This insidious cause of free water loss is often under-recognised in the ICU. The use of mannitol and other osmotically active agents may also contribute to water loss. Diabetes insipidus is the term given to the kidney's inability to respond to a high plasma osmolality by retaining water. Central diabetes insipidus occurs when there is an inability to excrete antidiuretic hormone, while in nephrogenic diabetes insipidus, there is a loss of the concentrating ability of the kidney. Examples are shown here. Urinary water loss also occurs following loop diuretic administration and after renal tubular injury, where concentrating mechanisms are impaired, even after urine output returns. Free water loss is the theoretical volume of water excreted that is completely free of electrolytes, given the patient's serum electrolyte concentrations. A common misconception is that urine osmolality higher than serum osmolality indicates free water retention. This is untrue, because there are many osmotic causes of free water clearance that are not electrolytes, such as urea and glucose. As such, a comparison of urinary electrolytes, and not urinary osmolality, with the plasma defines free water loss. If the sum of urinary potassium and sodium is less than that of the plasma potassium and sodium, the patient can be said to be in a free water losing state. Consider this example. In this patient, the urine plasma electrolyte ratio is 70 to 153, or 45%. This means that 55% of the urine is electrolyte free, an example of free water loss. This water loss is inappropriate for the degree of hypernatremia, suggesting an error with concentrating ability. Using the urine to plasma osmolality ratio alone would miss this important cause. Loss of water also occurs from the loss of hypotonic body fluids, such as excessive sweating, particularly due to high fevers, from burns, and from the respiratory tract, particularly if high ventilatory rates are used. Heat and moisture exchange filters, or humidified circuits, are nearly always used to combat this latter problem in ICU. Gastrointestinal losses can occur in high-volume nasogastric aspirates and due to diarrhoea of any cause. Cathartic use in liver patients is a common cause. Additionally, ileus can cause high volumes of fluid loss that can be concealed. As previously mentioned, hypernatremia is rarely due to excessive sodium administration, which instead leads to an expansion of the extracellular space. Occasionally, however, hypernatremia can be attributed to excessive salt intake, where the quantity administered overwhelms the body's ability to regulate sodium excretion and water retention. Sources of sodium in ICU can include sodium bicarbonate administration and certain drugs that are high in sodium. The most common formulation of sodium bicarbonate is 8.4%. At this concentration, there are 1,000 milliosmoles of sodium per litre. Frequent administration can easily overwhelm the compensatory mechanisms contributing to hypernatremia. Drugs that are high in sodium can include antibiotics such as timentin and tazocin. In one study from the Netherlands, in ICU patients with hypernatremia, a significant proportion do not have negative fluid balances and may even be in a positive fluid balance during the period of their hypernatremia. The authors of this paper concluded that in many cases there was too much salt and not enough water. Sodium retention in the face of high plasma concentrations is a very unusual cause of hypernatremia. This can be associated with adrenocorticoid hormone excess. Urine osmolality can help to assess renal concentrating capacity. However, this is not enough to assess free water clearance. Urine electrolytes are used to assess free water clearance as discussed previously. Failure of the kidney to generate water retention in the face of hypernatremia is highly suggestive of a defective concentration mechanism. The clinical presentation of hypernatremia is non-specific. As the extracellular fluid osmolality rises, there is an osmotic shift of fluid from the intracellular space. This is worsened in hypokalemia as the intracellular tonicity is reduced, further accentuating the osmotic gradient out of the cell. This results in tissue dysfunction, though the most common clinical features focus on central nervous system. This usually presents as depression in conscious state with stupor, delirium and coma common. Seizures are unusual. Focal neurological deficits may be present that do not reflect focal brain damage. Hypernatraemia is a frequent contributor to ICU confusion and delirium. Insulin resistance, impaired gluconeogenesis and cardiac dysfunction have also been described in the setting of severe hypernatremia. Marked hypernatremia may also present with fevers and leukocytosis, which may mimic early sepsis. Complications from severe hypernatremia include neurological deficits such as subdural hematoma, ischemic injury, and myelinolysis. It is thought that subdural hematoma formation may result from the shrinking of the brain, which causes stretching of veins in the subdural space, which occasionally tear. A similar mechanism may explain focal ischemic syndromes. A number of case reports have suggested that central demyelination syndromes have resulted from sudden increases in serum sodium levels, even in the absence of pre-existing hyponatremia. Venous thrombosis, likely due to volume depletion, sluggish flow, and concentration of plasma proteins, can occur in peripheral veins, resulting in DVT and pulmonary emboli, or in cerebral venous sinuses. The first priority is restoration of circulatory volume. In markedly volume depleted patients, resuscitation with normal saline is appropriate. As the concentration of sodium is lower than in the plasma, normal saline acts to lower the serum sodium concentration, though the effect is relatively small. Because initial bolus therapy has been associated with higher risk of cerebral edema, this should be avoided in the absence of circulatory compromise. Once the patient's circulation is restored, repletion of total body water loss can begin. Most cases of hypernatremia are related to impaired water regulation, and as such, water replacement and correction of underlying factors are the mainstays of therapy. The first step is calculation of free water deficit. This is the theoretical volume of electrolyte-free water that is required to return the concentration of sodium to normal. Water-free deficit is described by this equation. The equation can also be used to guide therapy by replacing 140 with the target concentration of sodium. This equation then calculates the volume of water required to achieve that concentration of sodium, assuming all contributing processes have been arrested. Recall that total body water is calculated as shown here. Where possible, the enteral route should be used for water repletion. No advantage in parenteral fluid administration has been demonstrated. The rate of correction of sodium concentrations remains the subject of controversy. The presence of hypernatremic encephalopathy may indicate the need for more rapid initial therapy, but in general, sodium levels should not be allowed to fall at a rate greater than 1 milliequivalent per litre per hour for the first 6 hours, and no more than 12 milliequivalents per litre in the first day. In very severe cases, a more cautious approach is necessary. The rate of development of hypernatremia is another important factor in decision-making on therapy. In response to the osmotic water shift from cerebral neurons, non-electrolyte osmoles are accumulated in the cells in an attempt to restore intracellular fluid volume. This process develops over time, usually days, and normalisation of the cerebral volume and hydration status means that symptoms of chronic hypernatremia are usually less apparent. Once developed, when these cells are exposed to hypotonic fluid, there is a rapid shift of water into these cells down the osmotic gradient, potentially exposing the patient to cerebral oedema. For this reason, when hypernatremia is chronic, rehydration with hypotonic fluids should be even more cautious than usual. In these cases, aim for a fall of serum sodium of less than 0.5 milliequivalents per litre per hour, with no more than 10 milliequivalents in the first 24 hours. During therapy, the patient should have frequent neurological observations taken to detect the possible development of cerebral oedema. Severe headache, vomiting, pupillary changes, motor posturing, and hyperventilation may occur, and the development of seizures is highly suggestive. Serum sodium concentrations should be measured every 2 hours initially to confirm that the appropriate rate of correction is occurring. The development of cerebral oedema carries a poor prognosis without prompt management. Risk factors for the development of cerebral oedema include more severe hypernatremia, an initial bolus of normal saline, more rapid fluid administration, and more rapid correction of serum sodium. Overly rapid correction may be managed by cessation of hypotonic fluids and administration of osmotic agents such as mannitol or hypertonic saline, and expert guidance should be sought. The use of hypertonic saline is covered in more detail in the hypernatremia video. An example is given here. A 70-year-old man presents dehydrated and delirious after being found on the floor with a fractured neck of femur. His initial serum sodium is 170 and he weighs about 70 kilos. Aiming to reduce his serum sodium by no more than 10 millimoles in the first 24 hours, the formula indicates he needs approximately 2.6 litres of fluid per day. Assuming that there are no ongoing losses of fluids and his normal requirement is 1.5 litres per day, he requires about 4 litres of water per day, or about 166 mils per hour. A number of calculators have been created for the impact of various fluid types on serum sodium. An example is provided here. Note that the presence of potassium also influences the changes in expected serum sodium concentration, as noted in this graphic. Excessive sources of salt administration should be avoided if possible, and underlying causes addressed. A common error is to neglect ongoing losses, or to overcompensate for them. This can result in unexpectedly small or large changes in sodium respectively. Monitoring sodium concentration regularly is therefore very important. In addition to fluid management, central diabetes insipidus can be treated with DDAVP. This can be titrated to effect on urine output. A common difficult scenario is hypernatremia in a patient with high total body edema. Administration of diuretics, such as furosemide alone, are insufficient to correct the problem, as they result in the loss of hypotonic fluid, which can exacerbate the hypernatremia. To overcome this, a combination of water administration and natriuresis are required. The impact of fluid therapy will be partly counteracted by the loss of electrolyte-free water from the kidneys. Obviously, the administration of fluids in a patient with volume overload requires caution and close monitoring. In some patients where renal function is impaired, either due to renal failure or poor perfusion, such as in chronic heart failure, it can be extremely difficult to achieve. In these cases, an extracorporeal therapy such as ultrafiltration or hemofiltration may be useful.